has been a true gentleman, scholar, gentleman, allowing his colleagues to go before him. Senator Cassidy.
Yes, and I have lots of questions, but even though I'm last, limited time, so I'll go a little rapid fire. It's been a fantastic panel, by the way. I don't know if we've ever seen this much kind of participation from members, and congrats to the chair. I think it's just gone very well, and you've all been really good. Dr. Swanee, happy Mardi Gras to all of those who are not as blessed as you and I to live in New Orleans and for this upcoming weekend. We've got to do something relatively quickly. Facilities for HBCUs, nursing, the pipeline, it's actually kind of okay, it finally gets there. One of the things that I've been thinking about how we could initially, boom, have an impact, aside from immigration change, which would be huge. Dr. Swanee, you mentioned the press of people coming to ERs and even the violence associated with. And I've read that we have an absence of medication-assisted therapy clinics. I'm assuming that a fair number of people coming to ERs, and Dr. Hildreth, you're in an urban area as well. Oh my gosh, Dr. Santon, oh my gosh, that if we had effective MAT in which we were keeping people from coming to the ER because they were less likely to be in overdose or withdrawal, that could be something that could be relatively quickly implemented to have a relatively rapid response. Dr. Swanee?
Senator Cassidy, thank you for that question. Look, I couldn't agree more. I think those are critical and important. I think it goes beyond just the medication assistance therapies programs. There's other interventions, like it was mentioned, digital medicine, digital monitoring, but there's actually digital management programs, digital hypertension, digital diabetes. We did a pilot in 3,000 Medicaid patients in rural areas where we managed their diabetes or their hypertension through the digital program. And we showed in 1 year in a Medicaid population, decreased hospitalizations, decreased ER visits. So I think you're right, Senator Cassidy. We need to move care into the community to prevent the ER visits.
That's been a theme from all of you. Dr. Steger, I have been just chomping at the bit to ask you this question. You ready? The sophistication of your research, you say that the pass rate of licensing exam is down. Now, you've done some sort of multivariate analysis. Is it who's less likely to pass? Is it the online school? Is it the for-profit school? Is it the person who graduated during the pandemic? Is it poor preparation prior to coming to school? What are the variables that can be affected?
So we're working on that, and I don't have good
answers. Oh, come on.
Yet, but I have some answers. The people who are not passing the licensure exam are people who were in nursing school during the pandemic. And all belief is that it was the,
So that cuts across your institution. Johns Hopkins all the way to your community college.
Well, I can't say Johns Hopkins specifically, but they are seeing it across the board in terms of the declining path.
Let me ask you then, online nursing instruction, which I'll come back to you, ma'am. Online nursing instruction, I'm a by-the-bedside person. And your quote, I'll steal it, Dr. Hildreth, I'll attribute it the first time, but then after that, I'll just forget you. Speaking to 100 people is a great way to teach, but a bad way to learn. So online seems like a great way to teach, but a bad way to learn for nursing skills. Am I right or am I wrong?
Well, I think the challenge has been particularly for clinical skills, right?
Yes.
That bedside skills. And the exam, and it's changing in April, focuses increasingly on clinical skills and clinical experience for the nurse licensure exam. So that is becoming, the belief is that the pass rate's going to get much worse this year, this next year because of that.
Because there's been lack of preparation for clinical.
Lack of the
so let me move on.
Experience
Dr.
with
Santon,
the patients.
I suspect you're chomping at the bit. Now, I endorse what Marshall said. The woman or the man that goes to the community college, I think is probably more likely to stay in her community. And I will just say from my personal experience as a physician, certificate nurses, the one that I worked with for 30 years, she was just fantastic. There's a clear bias towards BSNs, but it seems more expensive. It seems a longer pipeline to get them out. And again, as he says, there may be a predisposition for those folks to stay where they were trained at the university town as opposed to their community. So we got a couple things to throw before you. One, what about that? The Marshall issue. Dr. Steger, what about this kind of clinical skills gap? And what should we be thinking about in terms of online training and what I would intuitively think would make them less prepared?
Thank you very much for those questions. About the online training, so at Johns Hopkins, I can't speak for all nursing schools, but at Johns Hopkins, when we talk about an online program, what they mean is that some of the didactic portion, when you're learning about pathophysiology and you're learning about how the heart works, and that can be online in modules. But they come to campus multiple times a year, and they have clinical experiences wherever they are. There's at least at Johns Hopkins, there's no such thing as online-only nursing program. To your point, that wouldn't make sense.
Do I know that there's some online-only classes? Do I know that? Some universities all do 100% online. Dr. Steger, do you know that?
There's required.
There's during the pandemic, and there was
Yes.
typically no, right? They all.
Well, so for example, at Johns Hopkins, March 2020, everything shut down briefly.
Exactly.
We pivoted quickly, and people were back doing clinical hours. Sometimes they were more out in the community than in the hospital, for example, but people got really hands-on clinical experiences during the pandemic. I want to just mention about the RN. I wouldn't call it a bias, respectfully, towards RN, BSN education. That there's decades of evidence, and I'm sure you could back me up, showing that health systems that have a higher proportion of BSNs have better health outcomes for the patients. Of course, you need a team of all different kinds of people, but there's a lot of evidence that we'd be happy to share over time about that need for the BSNs as
Now,
well.
if the choice is between the marginal increase in an outcome, which again, you'd want a multivariate analysis to look at that, as opposed to having a shortage of nurses, which would be more impactful? More nurses or more of them being BSNs?
Yeah, nurses first, right? Then skills, then upskilling, and the evidence. National Academy of Medicine came out and this was their recommendation, so I won't argue with that. It's not perfect evidence, but it's good evidence. I think the key to the associate degree nurses is it's the entry and the career steps. It's a way for people to get in with 2 years, but then have a career ahead of them where they can get trained up to be a bachelor's nurse, and the key is facilitating that. That's how you get people to enter at these lower wage jobs, is they see the career ahead.
So with the upskill, can I have one more question? Dr. Hildreth, you alluded to, Dr. Stanton spoke of specifically, that if we address the burden of chronic disease, we can decrease our utilization. Dr. Swanee mentioned an innovative program in terms of digital health. We're going to have some hearings on pharmaceuticals, but whatever we say about pharmaceuticals, they've been incredibly innovative. We know the burden of metabolic disease disproportionately falls upon the poor, and that if we can do something about the metabolic syndrome, then we're going to decrease renal failure, hypertension, diabetes, heart disease, stroke. I say that, I'm not sure there's a question there, but just an observation, that there's been a consistent refrain that if we do something about the burden of chronic disease, that we can decrease the demand upon our healthcare facilities, if you will, a more fundamental way to address the shortfall as opposed to just more nursing schools, which we also need. Any comment on that, sir?
Thank you, Senator Cassidy. I'll just repeat what I said earlier. Our healthcare system is actually a sick care system. We need to be focused on the social determinants of health, where you live, where you work, how much money you make, your educational attainment. All of those things contribute much more to your health than going to see a doctor. Now, mind you, I'm in the business of training doctors, dentists, researchers, but the reality is that what we need more of is investment in public health. And I would argue that reintegrating public health and primary care is the best way forward, so we can actually get better outcomes for communities, not one person at a time. Thank you.
Thank you.